First of all, I would like to thank NAS Hospital, Dr. Donia, for his kind words and for the invitation today. The presentation and the cases, as you may know, that the second session is about the acute coronary syndrome. And I thought that it might be good to keep one theme for the whole day, so that the second session is about obstructed coronary arteries. And I thought that why not to make the first presentation or the cases in the first session about MINOCA or the unobstructed coronary arteries, and to keep it as one theme of acute coronary syndrome and the differential diagnosis of chest pains. Let's start with the first case, kind of warming up. If you have any questions at any time, please let me know. So the first case was a female lady, 52 years old, and back in 2010, while she was 42 years old, she was very young, she had typical anginal pain and severe chest pain, and at that admission, the discussion was that it might be a spontaneous coronary artery dissection. The patient underwent many investigations, lab, catheter that we will see shortly, but the catheter came unobstructed coronary arteries, although that the presentation and the labs were pointing towards myocardial infarction and anginal pain. The patient received conservative medical treatment, sent home. 2 years later, came with a myocardial infarction, again same presentation, chest pain. At that time, the MDT discussion said, well, the patient 2 years ago had the catheter, so let's do another modality. So the patient underwent a stress MRI. Let's go through first the catheter. That was 2010. So the left system was fine. Circumflex and lead was patent. There was no obstruction, no stenosis. Again, the left system. And the right coronary artery. Good caliber arteries. There was no significant obstruction. And as we mentioned, the patient was sent home at that time, medical treatment. And 2012, with the second attack, that the MRI, short axis, cine, showing the functions. Any comment from the audience? I think I don't see any regional wall motion abnormalities. Functions appear fine and preserved. No dilatation. No signs of any impairment. This MRI was a stress MRI, but before showing the stress images, this is the late enhancement. And the late enhancement showed a small focus of transmural enhancement, which seems to be of ischemic or of coronary cause, but it's a very small focus. And again, the patient didn't receive any intervention. The patient was discharged on medical treatment. Those are the stress images. So the upper row is the stress images. The lower row are the rest perfusion. And as you may see, there is no stress defect. There was no signs of any inducible ischemia. Therefore, the patient was sent home or discharged on medical treatment again. And there was no specific or a clear cause of what's happening at that time. Eight years later, so in 2020, last year, the patient, again, a third attack, same presentation, typical anginal pains, elevated and raised troponin. ECG showed a right bundle branch block. And although the patient had an echo, the echo returned back normal, no regional wall motion abnormality. So again, the discussion and the MDT discussion was that they were conservative of sending the patient for one more time catheter. So they decided, because of the age of the patient, she was very young. So they said, well, let's do a CT Maybe the CT would show something this time. That's her ECG. Again, the right bundle branch block. And the CT didn't reveal anything. So again, normal coronary arteries, no dissection, no signs of any calcification or significant plaques. Again, a discussion in the MDT, they said, well, let's go further. Another stress MRI. This is this new stress MRI, cine images, long axis, short axis, preserved function, no ventricular dilatation, and there was no regional wall motion abnormalities at the cine images. But how about the stress? The upper row again is the stress images, and this is the rest perfusion images. I'm not sure if the resolution, could anyone see the perfusion defect?
It's infralateral subendocardial infarction.
Exactly. So this time the patient, the MRI, the stress MRI showed a perfusion defect. Although that we saw that the catheters, the CT, the previous MRI didn't show any obstruction of the coronary artery, but this time there is a perfusion inducible ischemia under stress. And while we were stressing this patient, the patient showed a crushing pain as she described it. So this is here the perfusion defect. And she described a crushing pain. And we asked her whether to stop the infusion of the adenosine or not. She said no, she wants to continue. She was brave enough. And we continued around 6 minutes of the adenosine until we finished the whole scan. And it revealed the perfusion defect. This is a kind of a summary of what we had in the recent MRI. So there was an area of transmurality here of late enhancement. And the stress, this is the stress, the perfusion defect that we saw in the videos. This is the rest perfusion. So this means that it's a reversible or an inducible ischemia, and it's larger than the late enhancement. So there is a peri-infarction reversible inducible ischemia. And in the T2 maps and the T1 maps, the T2 time and the T1 relaxation time was prolonged, which reflects an acute event at that time, which means that this infarction and this inducible ischemia is recent. It's not old one, but it's a recent attack. Could anyone guess what would be the differential diagnosis of this perfusion defect in presence of unobstructed coronary arteries, as we saw in the CT, the catheters and everything?
Like the microvascular obstruction?
Exactly. So this is one of the differential diagnoses, would be microvascular obstruction or a coronary spasm. Probably this is going to be the differential diagnosis in this case. So depending on, because of the results of the MRI that suggested that this perfusion defects reflects that it's of coronary origin. Edema reflects that it's an acute event. The patient was sent again to the catheter. The left system was fine, again the LAD and the CX. But the next slide, on the left panel, kindly focus on the distal segment 3 of the RCA. This one is before giving the patient nitrates, and this image, this panel is after giving nitrates. And if you may see, or as you may see, that here the caliber was very reduced and very small, and after giving the nitrates, the caliber increased in size. So the diagnosis again was coronary spasm that have been taking place all the time. The patient was discharged from medical treatment, no intervention, and the patient came twice so far for the follow-ups in the clinic, and she's doing very well. And I think the MRI has narrowed down the differential diagnosis, has helped in changing the management of this patient. And the recent MRI, as a matter of fact, revealed the differential diagnosis, or the diagnosis in this case. Any questions before moving to the second case?
خلاص بلاش.
There is a question, Dr. Ahmed. Why in the vitamin stress test, the first one, the defect wasn't there?
In 2012, the MRI, the stress MRI.
Yeah.
Well, as you may know, that the coronary spasm is always temporarily. So it could be that the attack at that time, when the patient was admitted and until the patient received the MRI, it might be that the spasm was not existing at that time.
يا دكتور بعد اذن حضرتك، فهو ما كانش باين في الاول يمكن لان التروبونين ما كانش elevated at that time، فما كانش فيه significant ischemic burden ممكن يعني، ولا
هو السؤال the question is why the MRI, the first MRI didn't reveal it, or why did the troponin wasn't high? Because at the first presentation the troponin was slightly elevated as well.
يعني السؤال زي ما حضرتك طرحته في الاول، ليه رغم من حتى لو التروبونين كان عالي او mildly elevated، ليه الستريس CMR didn't detect the perfusion defect?
The first MRI could be that the first attack, that the spasm was already relieved, because sometimes the spasm are very short period, they are not permanent state. So it could have happened that the spasm at the time of the adenosine, the first adenosine MRI, wasn't that significant. But then in the second attack or the third attack, it was significant, and the spasm, we examined the patient while there is a spasm. And this is revealed in the catheter later on. It seems that the spasm was continuous over days. It wasn't just a short period, but it was over days, because the catheter was the following day after the stress MRI.
Okay.
Second case, a young lady, positive family history of HCM, and the patient came presenting with chest pain or chest discomfort. The patient received an echo that revealed asymmetrical myocardial thickening, more at the basal, and hypertrophied papillary muscles. ECG revealed some abnormal ectopy and incomplete right bundle branch block. I'm sorry I don't have videos for the echo, but those are static images as a kind of 4-chamber view, or we could see some hypertrophy in the basal septum. So this is the left atrium and left ventricle. And on the Doppler, so this is a kind of a 3-chamber view, there is mitral regurgitation, so the left ventricle, left atrium, and the outflow tract. There is mitral regurgitation in the Doppler and the echo. And